All right. Well, thanks very much, Dr. Moses. And again, I want to thank Drs. Cookson and Gerard for including me in the faculty. It's been an honor to be able to be part of this course over the past several years, so certainly looking forward to today's interactions. I am not Dr. Gamello. I don't have a joke at the fingers. So I think this is going to be the next talk.
You can give it if you like.
I was going to say, I'm not ready to give Dr. Gamello's talk, so no joke, no talk. All right. Okay, I was going to say, we may actually have to phone a friend for others because I can't sing either. All right, there we go. Yep, I see that one. Double click. See some promise on the screen? Okay. Perfect. All right. I'm going to be covering identification and management of what we would call treatment failure after local prostate therapy. My financial disclosures are all in non-muscle invasive bladder cancer, so not relevant here. I do want to acknowledge that much of what I'm going to be speaking about is coming from the recently released AUA Astro SUO guideline on salvage therapy. That's going to be presented in greater detail at several different points during the meeting here. I had the privilege of participating in that guideline panel. And I really want to divide this talk into three parts. First, to discuss the entity of biochemical recurrence, then talk about what we know in terms of salvage radiation as a treatment modality for biochemical recurrence, and finish with a little bit of what have been historic and now perhaps current and future systemic therapies for patients with biochemical recurrence. So I think it's very important to just start by AUA guidelines, kind of what's the letter of the law, how do we define biochemical recurrence after radical prostatectomy, and that is defined as a PSA greater than or equal to 0.2 with a second confirmatory value greater than or equal to 0.2. So I think just sort of level setting is an important place to start. But I think also when we think about our patients in clinic next week, we have to acknowledge that not all patients with a detectable PSA after surgery are at the same risk to then develop metastatic disease or death from prostate cancer. And with that in mind, several groups have looked at the concept of whether or not we can apply a risk stratified definition to biochemical recurrence. This is one such study that looked at 14 different definitions of biochemical recurrence and correlated it with patients' disease risk. Disease risk in this study was estimated by a nomogram predicted 5-year progression-free survival. And they came up with all sorts of curves like this. But really what they found was that if a patient had a nomogram predicted 5-year progression-free survival less than 50%, indicating that patient has high-risk disease, the best definition of biochemical recurrence is actually a single PSA greater than or equal to 0.05. On the flip side, if a patient has a nomogram predicted 5-year progression-free survival more than 90%, indicating low-risk features, then the best definition of biochemical recurrence is a PSA greater than or equal to 0.4 and rising. So really the take-home here is that we may use a lower threshold of PSA to define, and as we're going to talk about, to treat patients with higher risk disease. I'll spend one slide on biochemical recurrence after primary radiation therapy. What should you know about it? First, how do you define it? Phoenix criteria, which is the nadir PSA that a patient achieves after radiation, +2. Second, what do the guidelines tell us about how to evaluate patients? In a patient with biochemical recurrence after primary radiation therapy who would be a candidate for salvage local therapy, we should do a biopsy to document local recurrence. What is the inflection of that? The inflection of that is that in 2024, a positive PSMA PET after radiation in the prostate does not by itself define local recurrence, you need to do a biopsy. What happens if you do the biopsy and you document local recurrence in a patient who is a candidate for salvage local therapy? Then in a shared decision-making approach, we should offer the patient salvage radical prostatectomy, cryoablation, HIFU, and re-irradiation. Back to biochemical recurrence after surgery. Biochemical recurrence has been reported in about a third of patients who undergo radical prostatectomy, and as we shift towards operating on higher and higher risk disease, it'll be interesting in years to come to see if that number goes further. What's important to know about the natural history of biochemical recurrence? It's important to know that the natural history of biochemical recurrence is heterogeneous, and it is often quite prolonged. What do I mean by heterogeneous? Well, biochemical recurrence nearly always comes before systemic progression or death from prostate cancer, but biochemical recurrence by no means universally translates into systemic progression or death from prostate cancer. Many, many more men have a detectable PSA than ever develop clinical progression bone metastatic disease. We have to remember that these patients often are over the age of 60 and sometimes 70. They have competing risks of mortality, and in fact, one study documented that patients with biochemical recurrence were as likely to die in the next 15 years from their competing risks as they were from prostate cancer. Now, what do I mean by the time course of biochemical recurrence is quite prolonged? This is an observational cohort study from Johns Hopkins that's become known as the POUND study. It followed 304 men with biochemical recurrence after surgery for a mean of just over 5 years, and during that time, they found that approximately 1/3 of patients developed metastatic disease, that the median time from biochemical recurrence to metastatic disease was 8 years, from metastatic disease to death from prostate cancer was 5 years, which gives us this 13-year window that's often quoted from biochemical recurrence to death from prostate cancer, and that's in a publication from 1999 before all of the treatments that we're about to hear about the rest of today, which have continued to increase those sorts of timelines. Again, importance of considering competing risks here. Now, just as we have to think about a risk-stratified definition to biochemical recurrence, it's also important that we think about patient risk, individual patient risk, as well as disease features. This was a multi-center study of over 2,200 men with biochemical recurrence that were followed for just about 4 years. And what they did was they developed a prognostic model, a nomogram, to predict the risk of death from prostate cancer among men with biochemical recurrence. So what they put into the model? Well, age at diagnosis, that's sort of a nod towards competing risks of mortality. They put PSA parameters, PSA doubling time, PSA at biochemical recurrence, and then they put pathology from surgery, Gleason score, margin status, tumor stage, nodal status. And basically, I show this to you as one tool that you can use to estimate the risk of death from prostate cancer among patients with biochemical recurrence. Now, what do the new guidelines say? Well, the new guidelines don't advocate for one prognostic model or another. They just say that we should use prognostic factors, and several of them are provided in the guidelines in this table here, to counsel patients with biochemical recurrence about their risk of subsequent clinical progression. And you can see the variety of different clinical pathologic features that the AUA has listed here. What about imaging? What do the guidelines tell us? How should we stage patients who now have a rising PSA after surgery? There's a couple of statements. The first one is that in a patient with biochemical recurrence, we may obtain a PSMA PET CT scan for staging. However, what they go on to say is that in a patient with biochemical recurrence in whom we are considering salvage radiation, we should obtain a PSMA PET scan. Why? Because you want to exclude extrapelvic disease or distant metastatic disease from patients in whom you are considering a directed salvage local therapy. But on the flip side, I think it's very important that we are careful, and this is really one of the take-home points from my talk here. What should we do if a patient has biochemical recurrence, we get a PSMA PET scan, and it's negative? Don't withhold the salvage radiation. That's a very clear statement here. Clinicians should not withhold salvage radiation if the PSMA PET is negative. Why? Because the detection rate is not high enough for microscopic disease that may be present and may be effectively treated with salvage radiation therapy. We're getting the PET scan to exclude extrapelvic disease, not necessarily to identify intrapelvic disease. Is there any role to still obtain conventional imaging in biochemical recurrence? Well, the guidelines tell us that we may still obtain a pelvic MRI. Why? Because of the potentially enhanced detection of prostatic fossa recurrence together with PSMA PET scans. So you may get both. Now let's talk about treatment of biochemical recurrence now that we understand how to define it and how to risk stratify patients. Guideline statement number 1 here is that we should inform our patients that salvage radiation therapy is most effective when given at lower levels of PSA. And that's really the term that I've put on this slide here, early salvage radiation therapy. Data to support early salvage comes from several different series. These are data from the Mayo Clinic Radiation Oncology Group, 1,100 patients treated with salvage radiation, followed for 9 years. And what they found was a key prognostic factor was the pre-salvage radiotherapy PSA. So for patients who got their salvage radiation with a PSA less than or equal to 0.5, they had significantly lower risks of secondary biochemical recurrence, development of distant metastatic disease, and death from prostate cancer. This is a multi-center experience of almost 2,500 patients treated with salvage radiation, median follow-up of 5 years. And what they found was that if you got salvage radiation with a PSA less than 0.2, your subsequent 5-year biochemical recurrence-free survival was over 70%. If your PSA was 0.2 to 0.5, it was 63%. But as soon as you start to get salvage radiation with a higher pre-treatment PSA, you can see how the biochemical recurrence-free survival goes down, advocating for early salvage radiation therapy. So what do the guidelines tell us? First, that we should provide salvage radiation with a PSA less than or equal to 0.5, and that for patients at high risk for progression, we may even offer it at a PSA less than 0.2. A clinical question that often comes up when we're thinking about salvage radiation to the prostatic fossa is, should the pelvic lymph nodes be radiated at the same time as well? We now have this NRG RTOG 3-armed prospective randomized trial to help inform this question. One of the arms in the trial included prostatic fossa radiation, short-term ADT, and pelvic lymph node radiation. Primary endpoint of the trial was freedom from progression. Trial had a follow-up of over 8 years, and what they found for the primary endpoint was that the cohort of patients who got pelvic lymph node radiation had a significantly better freedom from progression rate, significantly lower progression to distant metastasis, and significantly lower risk of death from prostate cancer. On the flip side, there was no difference in overall survival in the cohort who got pelvic lymph node radiation, and pelvic lymph node radiation was associated with higher acute toxicities and an increased risk of late greater than or equal to grade 2 blood and bone marrow events. So collectively, that evidence led the guidelines to state that we may expand the radiation fields to include the pelvic lymph nodes, but that we should counsel our patients regarding the increased side effects of pelvic lymph node radiation. A second clinically relevant question that comes up when we're talking about salvage radiation is, should we add androgen deprivation therapy at the time of salvage radiation? We have several prospective trials to help inform practice here. This is a French trial that randomized patients getting salvage radiation to 6 months of ADT or not. Primary endpoint, progression-free survival, over 700 patients, over 5 years of follow-up. Adding 6 months of ADT to salvage radiation significantly improved progression-free survival with a hazard ratio of 0.5. They then extended long-term follow-up and confirmed the results from the primary analysis as well. A second prospective trial that's gotten a lot of attention from the New England Journal of Medicine randomized men getting salvage radiation to 2 years of high-dose oral bicalutamide or not. Again, over 700 patients, now 13 years of follow-up, and a primary endpoint of overall survival. What the trial showed, adding bicalutamide to salvage radiation significantly improved overall survival, significantly decreased the risk of death from prostate cancer. Does everybody who's getting salvage radiation need ADT as well? There have been a number of studies that have tried to identify if there's a cohort of patients that may benefit the most. This is a secondary analysis of that New England Journal of Medicine trial that looked at the pre-treatment PSA as a potential prognostic factor. They looked at a cut point of 0.6. And what they found was that among the patients who got what we would call late salvage radiation, radiation at a PSA more than 0.6, adding ADT was associated with better overall survival. On the other hand, for patients getting what we would advocate for, early salvage radiation, adding ADT was not associated with better overall survival, but on the flip side was associated with increased risk of other cause mortality, perhaps due to higher, greater than grade 3 late cardiac and neurologic toxicities. These are the curves from that study. Early salvage radiation, ADT, no difference in overall survival, worse other cause mortality. So, what do the guidelines tell us about adding ADT to salvage radiation? First, that we should offer ADT with salvage radiation to patients who have any of the variety of high-risk features, and they're listed here, including lymph node positive disease. On the other hand, of course, shared decision-making, when we're thinking about adding ADT, we should discuss with patients the side effects and the interaction with their existing medical comorbidities. For patients without any high-risk features getting salvage radiation, we may use radiation therapy alone. How about the details of treatment delivery with ADT? When we're going to add ADT to salvage radiation, minimum of 4 to 6 months, may even extend it up to 2 years. But I will say the guidelines still do put a cap on the amount of systemic therapy that we should be giving together with radiation. What do I mean? That the guidelines tell us we should not add docetaxel with ADT to patients getting salvage radiation. And for lymph node negative patients, AR suppression beyond ADT should really only be used in the setting of a clinical trial at this time. I'll finish with a few words about systemic therapy alone for patients with a rising PSA and no evidence of metastatic disease. So ADT alone, we heard a little bit from Dr. Moses about this, and it's covered on the Advanced Prostate Cancer Guidelines. Several retrospective series have looked at what happens if you just treat patients with a rising PSA with ADT. The study on the left, a little over 2,000 men with biochemical recurrence after either surgery or radiation. ADT alone, no association with all-cause or prostate cancer mortality. Study on the right, just about 6,000 patients with biochemical recurrence, again, after either surgery or radiation. In the patients with a rapid PSA doubling time, less than 9 months, ADT was associated with decreased all-cause and prostate cancer mortality after both surgery or radiation therapy. So perhaps in certain patients. One prospective trial in this space to be aware of out of Australia and New Zealand called the TOAD trial. Almost 300 patients with biochemical recurrence after either surgery or radiation. Most of these patients were actually after radiation, randomized to immediate ADT or ADT at least 2 years later. Follow-up was 5 years, and although the trial was closed early to accrual, it did report significantly better overall survival in the cohort of patients treated with immediate ADT for biochemical recurrence. So, what do the guidelines tell us? Led by Dr. Cookson, the guidelines tell us we shouldn't routinely use ADT in patients with biochemical recurrence. We should preferentially refer those patients for observation or clinical trial enrollment. If we do use ADT, it should be intermittent ADT. But I've tongue-in-cheek put this here because in the last 6 months, we've had 2 trials report out that may perhaps in the future change the management for these patients. The first one was in the New England Journal of Medicine at the end of 2023. It's known as the EMBARK trial. It took patients with biochemical recurrence after surgery, radiation, or surgery and radiation who had a PSA doubling time less than 9 months and randomized them to either enzalutamide and Lupron, Lupron alone, or enzalutamide alone. Primary endpoint in the trial was metastasis-free survival. Median follow-up was over 5 years. And what the trial demonstrated was that adding enzalutamide here significantly improved metastasis-free survival. Enzalutamide and Lupron, and even the enzalutamide monotherapy group, as you can see here, significantly prolonged metastasis-free survival. The trial analyzed a variety of different secondary endpoints, overall survival, time to next neoplastic therapy, and very consistently, use of enzalutamide associated with significantly better outcome metrics for each of these endpoints. Also, very importantly, the trial looked at quality of life. No evidence of quality of life deterioration in the cohorts that received enzalutamide therapy. So, in November of 2023, enzalutamide received FDA approval for use in patients with biochemical recurrence. I would submit before we start going out and writing a bunch of prescriptions for enzalutamide that there are a number of questions that remain about this trial that are worthy of dissection. The median entry at the trial with PSA was 5. And these patients were staged with conventional imaging, not PSMA. So we can talk in the discussion what would be the likelihood of a positive PSMA scan in a patient that comes in with biochemical recurrence in a PSA of 5. Was this a truly non-metastatic population? We don't know what the impact on subsequent therapies will be by using enzalutamide so early in their disease course, and of course, there is the cost to consider. Second trial just released in the Journal of Clinical Oncology known as PRESTO, looking at biochemical recurrence here after surgery. 85% of these patients had surgery and then salvage radiation therapy. PSA doubling time, less than 9 months again. Again, 3-arm randomization. ADT, ADT and apalutamide, or ADT, apalutamide, and abiraterone, maximum androgen suppression. Here, the primary endpoint was PSA progression-free survival, which we can debate, and the follow-up was just under 2 years. But what the trial showed was that intensified androgen suppression in both arms significantly prolonged the endpoint of PSA progression by 5 to 6 months, and you can see that from the curves here. Again, this was a trial that staged patients on entry with conventional imaging, not PSMA PET. Was it a truly non-metastatic population? The primary endpoint is of uncertain clinical significance, and ultimately we're left with the question, is a 5 to 6 month delay in biochemical recurrence worth the toxicity and worth, at a health system level, the cost? So what do I want to leave you with in conclusion here? First, biochemical recurrence, remember the AUA definition, but consider it in the patient's context as well. Recognize that the natural history of biochemical recurrence is heterogeneous and often quite prolonged. So consider competing risks, look at those high-risk features. Evaluate biochemical recurrence with PSMA PET, especially if you're thinking about salvage radiation, but don't withhold the salvage radiation if the PSMA PET is negative. When we talk about salvage radiation therapy, earlier is better, for sure less than 0.5, maybe even less than 0.2, may radiate the pelvic lymph nodes, should offer ADT in patients with high-risk features. In terms of systemic therapy for biochemical recurrence, don't routinely utilize ADT alone. Enzalutamide is now approved, but remember its toxicity, remember its cost, and keep in mind what we talked about in terms of the long-term natural history of biochemical recurrence. So with that, I'm going to stop and thank you for this opportunity to speak here this morning.